welcome Dr. Sam Klempner from Massachusetts General Hospital, and he will present on ctDNA and MRD in GI cancers.
All right. Well, I want to thank Sarah for bringing me back to Nashville. I got to see a college friend last night and haven't been back here since his wedding, which was a lot of fun. So good choice on the location. These are my disclosures. All right, so I think everybody here knows that GI cancers are bad. Most of our patients recur, so I take primarily care of stomach and esophageal cancer patients. And we don't cure many of our patients. It's really unfortunate. We present late. Neoadjuvant therapy cures some people, but we have a lot to go through just to get that cure. Big surgeries, a lot of quality of life impact. And we actually don't have very good predictors of who's going to do well after neoadjuvant therapy. This is just a curve from the FLOT4 trial, which is old, but you see what I'm pointing out is where it levels out is just a little bit above 40%. So those are the cures. You know, these are like less than half of people are being cured in stomach cancer. And colon, you guys do a little bit better than us. And why does this happen? Well, we presume that the main reason that patients recur when we have clinically localized disease is that they have undetected distant disease. We just don't have routine tools to detect these micrometastatic deposits that are probably underlying the ultimate recurrence. So our methods are poor. We'll talk a little bit about the performance of some of the tools we have. Certainly, there has been advances. So most of the advances have been around improving our systemic therapy. We presume that translates to better micrometastatic control that ultimately translates to the more cures. And that's a hypothesis because we haven't had great tools to detect micrometastatic disease. So before we had CTs, we had chest x-rays, and if you can see something on a chest x-ray, you're probably talking about 1 billion tumor cells, so that's something that's been there for a while, had a lot of time to evolve, a lot of time to interact with the immune microenvironment and become relatively resistant. CTs certainly decrease the limit of detection, but still, when you're talking about centimeter, a few millimeters, that's still a lot of tumor cells. So the biggest advances, I think, recently have been along the use of plasma-based technologies. And ctDNA is what we're going to focus on, but plasma proteomics and methylation, certainly these are things that can be integrated. And then I'm just giving a shout out to our surgeon who I think finds all kinds of crazy stuff when he does laparoscopies, but this is just an important thing. All right, so I realized that this is actually, I don't feel old that much. But I did feel old when I was looking for an analogy, and I realized this movie came out in 2001, just like 20-something years ago, and it's not, it is what it is. So let's talk a little bit about cell-free DNA. So there's an important distinction here between cell-free DNA and circulating tumor DNA, and the terms are actually important. So all of our cells turn over. You know, white blood cells have the highest rates of turnover, along with red blood cells, but they don't have a nucleus. And so the release of cellular contents into the blood is continuously happening in all of us. And those contents include fragments of the genome, and they're fragmented at certain lengths, and that's what we see in cell-free DNA. There's also, of course, if you have something germline, that's going to be picked up in the cell-free DNA, and there's actually a lot of interesting literature around release of normal cell-free DNA from muscle, from bone marrow, in the presence of other conditions like autoimmune disease, and that's interesting biology, but not what we're going to talk about. In patients that have cancer, the same processes are happening, but some of them are happening from the tumor cells. But tumor represents a very small fraction of our overall normal cells, and so the dark fish here is the cell circulating tumor DNA, and all the other stuff is normal. So there's a big onus on us to distinguish the normal from the tumor, and of course there's things that impact the amount of shedding. If you have a ton of tumor, your liver is full of metastasis, you have a ton of lung metastasis, those patients generally have higher ctDNA levels than someone who has only a very small amount of disease. And there's, of course, a lot of applications. I'm not going to talk much about the metastatic setting, but that's very, very interesting, where ctDNA for monitoring, for resistance, for early response prediction is relatively well established. This is just to drive the point home. that cell-free DNA is the most of it, the big fish that I caught, and circulating tumor DNA is the little tiny fish that my brother caught. And I also just have to remind everyone that I'm a better fisherman than my brother. This is a wahoo down off the coast of Florida a couple years ago that's really, really good sashimi. So as we all get older, our normal cells age. And when you're born, of course, you have a bone marrow that makes white blood cells. As we age, we have accumulation of somatic mutations. So these are mutations in normal cells, and they are shed into the cell-free DNA. And they've been increasingly associated with the development of conditions like heart disease and diabetes, high cholesterol, et cetera. And this is CHIP, so clonal hematopoiesis of indeterminate potential. And when you draw blood from older patients, you can detect mutations that are not coming from tumors. So this is going to become very important as we talk a little bit about how to interpret these tests. So there are broadly two main types of ctDNA assays at use in the non-metastatic population. So tumor-informed, this is where you're taking information from the tumor and using that to guide what you're going to probe in the blood. And so essentially what happens is we rely on our surgical colleagues or IR colleagues or endoscopic colleagues to get a piece of the tumor. You have to sequence the tissue to understand all the mutations that are present in that tumor. And in the bottom left, I like this figure. I can't take credit for it. I just adapted it. But all tumors have some early alterations, and we call those variants clonal events. They're shared throughout all the cells, all the clones of the tumor. As the tumor ages and becomes more heterogeneous and mixed population, you get some mutations that are only present in a subset. Let's call it 10% of tumor cells have the blue line, and 10% have the darker blue, et cetera. So those subclonal variants, if you were only going to look at a subclonal variant and it went away, you would not be measuring the other 90% of tumor cells that didn't have that variant in the first place. So that's why it's important to track clonal, or some people call them truncal events, because then you're essentially measuring tumor burden. As there's more tumor cells, they all have the same clonal event, early clonal events, and so that truncal event can essentially be a surrogate for the burden of disease. And so you need to identify the clonal variants, and that's done by sequencing the normal tissue and sequencing the tumor tissue, so you can sort of subtract out some of those CHIP alterations that we talked about. And then you have a panel of variants. You might identify 50, you might identify 200, and then you pick some and you select, and that's what you look in the blood for. And so these are unique to every patient. You know, my esophageal cancer is going to have a P53 and a cyclin E1 mutation, and et cetera. And yours is going to have something different. So my tumor-informed test is going to track the P53 and the CCNE1, for example. And if they're detected, it's presumed that there are tumor cells somewhere. So that is a positive test. So you get sort of a dichotomous yes-no. It doesn't matter. They're not telling you what the variants that we found. We found your P53 level went up or down. It's yes-no. And this is an approved platform for colon cancer. The tumor uninformed is basically trying to take the idea of, can we do the same performance without needing a tissue sample? And this is basically built around the idea of a predetermined panel. So, for example, if you look in the TCGA, P53 is shared very commonly across all tumors. And so if you were going to build a panel of genes to detect for cancer, you include genes that are commonly shared across cancers. So you build a panel and you can probably cover like 80–90% of the common genes altered in most cancers. And so that's what most of our advanced tests do, like Guardant 360 or Foundation Medicine or Tempus or Caris, et cetera. A lot of them are based on predetermined panels in the blood in advanced cancer patients. You don't need tissue for this. Obviously, that's the big potential advantage. You still have to address the somatic mutations in normal cells, so you have to filter out CHIP. Otherwise, you could be telling a patient that they have persistent disease, but what you're really just measuring is normal things that happen with aging. So you do that by essentially taking the white blood cells from the blood and sequencing those are the normal reference, and it's a patient reference. And so you subtract the normal from whatever else, and anything that's left over you presume is from a tumor. To improve the sensitivity, because when people have a very low burden of disease, there's not a lot of those darker fish swimming around. There's not a lot of circulating tumor DNA. So you can improve the sensitivity and the specificity by adding other parameters. So methylation, for example, is the most common one, but you could envision adding protein like CEA or CA19-9, and there are some assays that do that as well. This platform is also approved for colon cancer, and we'll talk a little bit about the data. So I think that background is important. I know it's probably a little bit more than a lot of you need, and you're familiar with this, but I'm going to limit this talk to the non-metastatic applications. And so just so we're all on the same page, minimal residual disease or molecular residual disease, whatever you want to say, we're talking about the presence of disease without any radiographic or other imaging evidence of disease. And so this sets up several paradigms where you can envision using this. And so obviously the most common one is after curative intent therapy in the adjuvant setting, but you could envision neoadjuvant setting, you could envision surveillance after the end of adjuvant therapy for early detection of recurrence. And we'll talk a little bit about the data that we have to support these indications. So first of all, it's pretty well established, and I think everybody probably knows this, that the presence of tumor DNA after you've done everything to try to cure the patient is very poor prognostic feature. I'm going to show you a couple data sets just to kind of convince you that this is true. This is from a gastric cancer paper. So essentially, these are all patients who in Asia presented with gastric cancer, and they had no therapy before surgery. They all got surgery, and then they looked at blood after surgery before adjuvant therapy. That's what ACT is. And then they looked at it after the completion of adjuvant therapy. So in Asia, it's common to have surgery, and then adjuvant, you might do K-pox, for example. And what they did is a tumor uninformed approach. They had a large panel that they looked for, and they filtered out the white blood cells, so try to filter out that chip. And there's a couple important observations. So these are mostly stage 2 and stage 3 patients. And one thing we learn is, like, how common is ctDNA in someone who has a stage 2 or a stage 3 cancer? Well, in their data, it was about 45%. So that means the person who walked in the door, new diagnosis, almost half of the patients had detectable cell-free DNA. So that tells you that there's also half that didn't. And so this test is not perfect. What about right after surgery? And so right after surgery, there was still about 20% of people, and this is in the near post-op period, that were ctDNA positive. So those are people where the surgeon said, we got everything, but the ctDNA is still positive. So you would presume that there's probably some micrometastatic disease. And to highlight sort of the sensitivity of these assays, we're detecting very small amounts of disease. And so it's not seen on imaging, and there's a pretty long lead time in some studies between when your test is positive and when your scan is positive. And in this series, it was about 6 months. And so we'll talk a little bit about that scenario where patients can be quite nervous. They know that this is bad, but what do we do? And so we'll talk a little bit more about that. This is from our own data in gastric and esophageal using a tumor-informed approach. And we basically saw something very similar. So after surgery, these are mostly esophagectomies and gastrectomies, again, we saw almost a quarter of patients were positive, and we had a pretty good sensitivity. And the main point is that if you were positive, within 16 weeks after surgery, that's what we defined as the MRD window, because that's the time you have to make a decision about adjuvant nivolumab from the Checkmate 577 trial. You're basically destined to recur if you're positive, where if you're not, there is a relatively low rate of recurrence. So very powerful prognostic piece of information. Again, this is pancreas, so I've shown you stomach, esophagus, pancreas, and we'll get into colon. This is actually, because most pancreas cancers have a clonal variant in KRAS, they have a very early KRAS mutation. It's an early event in the cancer. This series from Hopkins, essentially all they did was look for KRAS because it's present in so much of pancreas cancer. And this data you can see is from 2019, before we were really using bigger panels. And they showed the same thing. So all of this is just to say, this is bad. If you have positive cell-free DNA after surgery or after any curative intent therapy, you have a very high risk of recurrence. Most of our data is from colon cancer, so we'll spend a little more time there. This is the schedule, so it's important to understand like what's the frequency of monitoring, when do we draw these blood tests, and you can see essentially these are people who had upfront resection, so stage 2 or stage 3 colon cancer. About a month after surgery, they got a blood test, and then 3 months after surgery, and then they were followed serially. So these are the kind of cohorts we need to really understand the dynamics and the kinetics and how ctDNA changes. And again, same pattern here. So we see about 20% of colon cancers were positive in the first draw 4 weeks after surgery. That seems to be, interestingly enough, across all the series that I looked at while I was putting these slides together. They all kind of hover in that 18 to 30%, which is interesting to think about, but hard to know exactly. Probably it may be more. And you can see, again, your disease-free survival, if you're negative, is very good, whereas if you're positive, it's very poor. And when you compare this against other features that we normally use to tell and talk to patients, and we say, oh, you had lymphovascular invasion, this is a high-risk feature, or your post-op CEA was high. If you compare the performance of circulating tumor DNA against the normal clinical risk factors, you see that this is the strongest independent predictor of recurrence. So better than nodal involvement, better than T-stage, better than post-op CEA, et cetera. So I think that it's relatively established that this is a poor prognostic feature, but now the question is like, we're taking care of patients, so what can we do about it? All right, so we'll try to frame most of this second half in the context of this case. So pretty typical case, woman comes in, GI bleed, ultimately goes to have a colon resection. It's a stage 2B cancer with some poor prognostic features, and she comes in 3 weeks post-op to check in. And questions for all of us is a blood test going to help us? I mean, I think any test, if we're going to order it, we need to know what we're going to do with the result. What's the best timing? What test do you send? So these are all very fair questions from the patient. So first of all, let's talk a little bit about timing of the test. This is data from ASCO GI that was just presented for a very large real-world cohort. You see the 14,000 patients with 50,000 time points. I mean, this is a lot of data. And this is where some of our collaborations with the commercial companies really let us do things that none of us can do at our own institution. So we in Vanderbilt could say, let's pool our data, and we might get to like 150 patients. But when you want to tease apart subgroups, 150 patients is not enough. When you get into the 14,000 or 500 patients, then you can really look at some interesting questions. So it does highlight the success of some collaborations between commercial entities doing these tests and academic investigators. So this is all a tumor-informed platform, and they asked a couple simple questions. So does the timing of the draw affect the total cell-free DNA concentration? And what you can see highlighted in red, and this is just the annotated cohort where they had a lot more information, people who had their draw very early, so 0 to 2 weeks, that's the far to the, I guess, left, their average cfDNA concentration in the blood was high. And this is presumably related to what we talked about a few minutes ago. You know, normal cell turnover is going to release normal cell products into the blood. And so if you draw someone 5 days after surgery when they're still healing and they've got a lot of inflammation going on, you're going to see a high cell-free DNA total concentration. And as you get farther away from surgery, you see it go down. That's important because you could make a guess that if you have a lot of background, you might suppress your ability to detect your signal, which is what you want, of course. And so this is about the timing. So the next question is, does the timing impact the sensitivity? And this is essentially looking at cfDNA concentration and timing. And there's some first obvious kind of things that you expect. If you have a high stage, you have a higher chance of being ctDNA positive. And this is a multivariable analysis, of course, and it looks like concentration does not affect the positivity rate, so the test is still interpretable, even if it's drawn early, but it also tells you that the sensitivity at the early time point, the 2 to 4 week window, is very similar to the 4 to 8 week window. So this patient comes in 3 weeks post-op, and it seems that based on this data, it's reasonable to draw the test now as opposed to waiting till week 6 or 8, for example. So we've answered her question about timing. Yes, 3 weeks is very reasonable. Again, what test to order? We talked a little bit about the tumor-informed and tumor-naive, which is uninformed. This is just a reminder of what the differences are. And so let's say in upper GI cancers like where I am, a lot of times we don't have big tissue samples. So for example, someone with esophageal cancer gets a diagnosis on an endoscopic bite biopsy. Then they get neoadjuvant therapy, and Dr. Lander gives them the right stuff, and they get a total pathologic complete response. And so they go to surgery, and there's no tumor. So how do you build your test? You have to go back and use the original biopsy sample. And sometimes those have been used for other biomarkers, and there's not a lot of stuff left. Sometimes there's not a lot of cellularity in the biopsy. So you could envision a situation where, depending on the disease and the paradigm, you might be choosing the tests based on availability of tissue, et cetera. But both of these are very reasonable, and the turnaround time is getting better. The blood-only tests are a little faster because they don't have to sequence the tumor. And you can see in the tumor-informed, you have to build a custom test for each patient. So the first test takes a little bit longer, but subsequent tests where you already know what probes to look for in the blood are very quick, because then you're essentially doing very similar to a tumor-naive where you just need a blood sample. All right, so there's a ton of information, but it's a big difference between just having information and what to do with it. I don't remember where I got this cartoon. It's okay. So what can you tell the patient in front of you tomorrow when they come into your clinic? So we know that ctDNA is a very strong predictor of recurrence across GI cancers. After curative intent surgery, at least from the series that are out there, it seems that about 1 out of 5 or 1 out of 4 patients will still have positive ctDNA after you've done everything that you can to try to cure them. Both platforms are very reasonable. So tumor-informed, where you sequence a biopsy sample or a surgical sample to build a custom assay, or an uninformed, where you're taking a shared panel of common mutations and probing, are both very reasonable, and we'll talk about the data. Okay, so that's great. You convinced the patient that they have a positive test and they're at high risk. But does that change the results? So I think that as personally myself gets more experience with these platforms, and as all of us do, we really have to think carefully, and this is just the shared decision-making model, which I like. And it is a reminder to all of us that we have to present the data and say, what are the realistic expectations? What are the potential outcomes? And how are we going to manage those scenarios? And so this patient opts for ctDNA testing. She really doesn't want adjuvant chemo because she uses her fingers a lot. And so that test when you saw her that you drew at 3 weeks comes back as positive. So now what do you tell her? And what if you give her adjuvant therapy and she clears? Are you going to say, look, we feel really good about this now? All right, so let's start a little bit about the prognostic features and how that might impact the management. So this is from a very large series that was presented at ASCO GI last year, but just published in Nature Medicine very, very recently. It's a very nice paper. I would definitely encourage anyone interested to read this. But if you look at the high-risk people on the right who are positive after surgery, the question is, can we help those people with adjuvant chemo? Equally important, if you take someone who has stage 2 or stage 3 disease and they're negative after surgery, are you really going to help them by giving them adjuvant therapy? And if you look at these curves, particularly panel B, what you see is that the people with a negative test, the ones that got observation, which is the red line. Do I have a pointer here? Yeah. No. Maybe. Yeah, so the red line here is people who were observed. So they had a negative test and they were observed. And you see that those people did very, very well. But equally important, these are the people who had a negative test and got adjuvant chemo. And you see that they did exceptionally well, but there's really no difference here. So if that person has stage 2 disease and a negative test, do they really need adjuvant chemo? And we'll talk a little bit more about that scenario, but it's definitely very compelling data to suggest that maybe they don't. All right, so probably the best prospective data that's out there, and there's a ton of trials in this space, is this New England Journal paper from the Australian group, which is very good. They've been leaders in this field. So they asked a very simple question. Can a ctDNA-guided approach reduce the use of adjuvant therapy? So we don't want to harm the people that don't need treatment without compromising their outcomes. Of course, we don't want to forego a therapy that might improve survival. So it's a very clinically relevant question. They took a very clean population. So these are stage 2 colon cancer patients who had a complete resection. They were drawn at 4 and 7 weeks post-op. And so if you were positive at 4 or positive at 7, you were considered positive. You didn't have to be at both time points. And then patients are randomized here. If you're ctDNA positive, you can get adjuvant chemotherapy based on investigator choice. The negative patients get observation, and then there's adjuvant decisions based on other parameters. So basically a ctDNA guided versus a standard of care. Their primary endpoint here was recurrence-free survival at 2 years, which is a relatively decent surrogate for longer term outcomes like 5-year survival rates, et cetera, where we're talking about cures. So how did they do the test? This is a tumor-informed. So essentially you have, in colon cancer, we have big chunks of tissue because our surgeons are very good at getting out the tumors. We have a lot of material, so tumor-informed has a high chance of being able to be developed as a test, unlike the neoadjuvant paradigm I discussed. And so they looked for commonly altered genes in colorectal cancer where we really know what genes are commonly altered. They got the blood draw, and then if you had one of those patient-specific mutations, they called it a positive test. All right, so here is the main outcome. So you're looking at recurrence-free survival here, and this is a non-inferiority study, and what you see is that there's essentially no difference. At a median follow-up of 3 years, these are people who got ctDNA-guided management and standard management. So the people who had a negative test were spared adjuvant therapy potentially, and there was no compromise in their outcome as far as we can tell. There's probably people here that know this data better than me since I stay a little bit on the other end of the tube, and there's some nuances, but I think the take-home message is that this supported the idea that in negative tests, we can potentially forego adjuvant therapy. This is a little more data. So what you're seeing here is the people who got ctDNA-guided therapy for a positive test and were treated with adjuvant therapy, they do okay. So this suggests, and I'll give you another piece of data on the next slide, that there actually is a portion of patients who are positive after surgery who we can convert to negative and still cure them, because that's a very important question. If you have a positive test and none of our therapies make the positive go away, then that's a problem. We don't have effective therapies in that situation, but thankfully, so far the data suggests that we can clear positive tests with adjuvant therapy. If you compare that to what would happen to those people if you did nothing, again, you see that in this observational cohort, the people without chemo who are positive, they have very poor outcomes, very high recurrence rates, whereas the people who got chemo with a positive test, their outcomes are better. So it suggests that adjuvant therapy in a positive test can convert people to negative and save some people. This is really more of the same thing, but it's a fair question to ask. Your patient comes in, they have a positive test, and they say, what's the chance that this adjuvant therapy is going to make my positive become a negative? Well, from colon cancer, we can say that it's actually not that bad. In the dynamic trial, almost 90% of people had their ctDNA cleared 4 weeks after completing adjuvant therapy. And those people that were positive after surgery and got adjuvant chemotherapy and converted to negative did very well. So those people, adjuvant therapy probably helped them, maybe cured them. Whereas if you stayed positive, it suggests our adjuvant therapy was ineffective. You're basically destined to recur. I mean, you see that drop off there. The hazard ratio is huge here, 55. This is a similar pattern that was observed in a second large data set in Asia, where they showed a very similar idea that if you cleared, and here it's about 2/3 of patients clear by 6 months after surgery, it's a little bit longer time point, you see basically the same thing. If you cleared with adjuvant therapy, you do very well. This is more to try to convince you that that is actually important. Clearance is very favorable. Here are just several curves from the same paper looking at people who were persistently negative, they do very well. People who converted from negative, people who converted to a positive, you see they are more similar to the people who were positive all along. So it just reminds us that this test serial time points can actually be quite helpful, because the first time point tells you positive after surgery and you have a high risk of recurrence, and that might inform your adjuvant decision. And then serial time points like middle of adjuvant therapy or maybe at the end of adjuvant therapy where we have more data suggest that then you can feel better about telling the patient that, look, adjuvant therapy cleared your ctDNA and now you're going to track more like this blue line. These people do pretty well. So I think we have data to support initial testing and then a utility for serial testing, or at least at the end of adjuvant therapy. All right, so back to our patient. So she goes for 3 months of K-pox. She converts to negative. She was positive in the beginning. And the dynamic trial would suggest that the people who were stage 2, like our patient, you can actually reduce the usage of chemotherapy. So in the negative population, which is not her, they actually were able to substantially reduce the use of chemotherapy in the negative population from 28 to 15%, and this is no compromise on the outcomes. And so negative people do really well without adjuvant therapy, and that's important. Our patient was positive but converted to negative, and so she's likely to do well as well. All right, so now we'll move to sort of the next paradigm in the last 10 minutes or so. This is our patient. Let's say they converted to negative and they were followed for a while, but now, a year and a half after their adjuvant therapy, they have a positive test. Can we do anything for those patients? So we know that they're very likely to be destined to recur. They may have negative scans, but if we intervene early where we know that we're probably finding some micromets somewhere, can we help those people? So this is just a case example to highlight exactly what this would look like in real practice. So this could be our patient. This patient got 6 months of adjuvant FOLFOX and then serial testing after turned positive. And one, you can see that there's a relatively long lead time between, well, you can see that the workup for the positive test did not reveal anything on imaging, but found a rising proportion of this cell-free DNA mutation, in this case APC. And so this patient is very likely to recur, even though there's nothing to see on scans or colonoscopy. So the bottom line is we don't really know the answer to that scenario yet. There's a lot of trials being led by multiple people around the country and around the world. Obviously, I have to give a shout out to my colleague, Dr. Parikh, who at MGH designed and is leading this trial. It's essentially asking the question of this scenario. People who completed adjuvant therapy but now have a positive test, so you presume they have residual disease somewhere. If we intervene at that time point, can we help those people? And that's an open question and a very, very important question. And there's multiple studies that are doing this same exact question. And so the options are here. Do you do like early therapy that you would do for metastatic disease? Like they finished FOLFOX, do you give them adjuvant, well, not adjuvant anymore, but let's call it early or delayed adjuvant FOLFIRI? Or do you introduce biologic agents? And so these are all questions and multiple approaches to this clinical scenario. So right now we have good data to support ctDNA guidance in adjuvant therapy, choosing adjuvant therapy. But after the completion of adjuvant therapy and a positive test, this is a huge area of interest, and we don't have strong data where I could stand up here and tell you that someone who has a positive ctDNA after 3 months of FOLFOX, they should start FOLFIRI right away because we can help them with that. We don't know the answer to that question yet, but I suspect that some of the people in this room will probably lead the studies that help us to answer that question. So this is the scenario for the patient. Again, this is a tough one, and I don't think anybody knows the answer. I've struggled with this in my own clinic, and so I'm a believer in this approach. We do this a lot. We have the discussion with our patients. We have the discussion about, okay, at the end of your FLOT, if your test is positive, we're going to worry a lot, but we don't really know what to do. And so just to be clear, we don't have randomized data in this scenario to say that early action improves survival. but that is the hope. So my take-home message is that if you have patients in this scenario, the only way we know this is by developing these huge repositories shared across institutions, et cetera, because then we can tease apart the groups and the trial designs, et cetera. So there's a lot of easy ways for patients to participate and for clinicians to participate. So if you have access to one of the registries or an interventional trial, the faster we accrue these trials, the sooner we'll get the answers. And then if I get invited back ever again, I can tell you that now we have data after adjuvant therapy that you can intervene. So I talked a lot about colon cancer. And yeah, I like that one too. My dad builds furniture, so this was like a recognition to him. He never asked me to do that, but I did learn about the safety of round power tools. So all the data is in colon, but can we extend this to other GI cancers? So from what we know, it looks like the story is holding. It's mirroring in other tumors. It's not yet standard, but if you are interested in this and the patients, I think it's a reasonable consideration in other cancers. For example, we do it in esophageal cancer routinely, although fully admit that that's not standard of care. But obviously, we're interested in the research and trying to improve the standard of care, so I think it's an important goal. The management of localized non-colorectal cancers, to actually say that, okay, the same thing I just told you about stage 2 colorectal holds for stage 2 stomach cancer, that would be a lie. We don't have that data yet, but I fully expect that it will be the same story, and so just ctDNA is a tool. It's not the end-all, be-all, but it's a very important tool. I think probably several of you are sitting there thinking like, well, what about putting our surgeons out of business? What about neoadjuvant therapy? No offense, but there's a lot of future promise here, and this is just a series from Stanford to highlight the potential of this. So this is a very small series of esophageal cancer patients, 45 patients, and these are people who were initially thought not to be resectable, so they weren't going to go to surgery, and they were basically asking the question about the kinetics of ctDNA during neoadjuvant therapy. So everybody got chemoradiation, basically like cross, and what you can see is that one, at baseline, a lot of patients were detectable, which tells us it's a tool we might be able to use. Interestingly, squamous cancer shed a lot more ctDNA than adenocarcinomas, just a random tidbit. And so people who had residual ctDNA detected after the completion of chemoradiation, it was bad. And those, you can see those curves are like a dive bomb straight down. Whereas the people who cleared actually did quite well. And these are people that you could say, oh, maybe they don't need surgery, or maybe we eradicated their disease and maybe they should have surgery when we initially thought that they didn't. There's also an interesting observation here. One, as I've shown you before, the ctDNA precedes imaging recurrence by quite a long time here, about 3 or 4 months. They also did something interesting. So they used a tumor-informed assay in the beginning to identify the variants to follow, but they also did an uninformed. And so they combined both approaches, and there was a few patients that they picked up on the back end with the uninformed approach that were missed on the tumor-informed approach. And this is interesting, and it's very small, so it's hard to say a lot more. But I think we may ultimately move to actually leveraging both of these approaches to get the best of both worlds, kind of. This is just another example to think about the potential. So for MSI-high, localized gastric and GE junction cancers, we've seen a lot of data to suggest, just like our colleagues in rectal cancer, that if you give neoadjuvant checkpoint inhibitor to this subgroup, they often do exceptionally well. So this is now published, but it's essentially 3 months of checkpoint inhibitor, surgery, adjuvant nivolumab. And so you could envision when you see outcomes like this, where 60% of people had a pathologic complete response, and preliminarily you see a curve like this. So essentially a totally flat line. And the question there is like, okay, these patients are doing exceptionally well. Did they really need the operation? So 6 out of 10 of them had no cancer at the time of surgery, and even the people that did have some residual cancer cells doing exceptionally well, and maybe they would have been a path response if you had waited a little bit longer after the neoadjuvant checkpoint. So you could very clearly envision a scenario where you take your treatment, if you cleared ctDNA, you randomize someone to surgery or surveillance, and there is actually a trial that's doing this right now, which I did not put in here, but it's called the Infinity trial, led out of Italy by some friends, and they're asking this question. So I'm really just showing it to highlight the additional applications of ctDNA in the field of non-metastatic GI cancers. And I'm down to the last couple minutes, so I think the take home is that this is a tool that patients are going to come in asking for. We all need to know the basics. Tumor-informed versus uninformed, how to manage a positive test, etc. Both uninformed and informed approaches, so blood only or tumor plus blood, are very reasonable to consider. I think it's an individual decision which one you select, and maybe there are some clinical factors like tissue availability, etc. We know that if you're positive after we've done everything for you, you have a very high rate of recurrence. It's a very high-risk group. It's probably the strongest independent predictor of recurrence of any of our tools out there. There is now compelling data for stage 2 resected patients with colon cancer that ctDNA can be used to actually inform your decision about what you're going to do for these people. So this is great. Now we have another tool that can help us pick patients and reduce exposure to potentially toxic adjuvant therapy without compromising outcomes. And there's a lot of room to do better here with other applications, other GI cancers, and I think there's a ton of data that comes out like every week. So, you could have a conference like this every 6 months and there'd be a new paper that potentially impacts our management. So I spend my time outside the hospital on farm that I grew up, and I just want to thank everybody for the time and happy to take any questions.
Hey everyone, I'm Eric, fellow at Vanderbilt. Thanks for the great talk, Dr. Klempner. You gave a lot of data about how we manage patients with ctDNA in the colon cancer setting. I know there's not a lot in upper GI. You said that you do it though routinely. How does that impact management for you in your clinic when you're getting it in upper GI cancers? Generally speaking, say like in the adjuvant setting.
I thought we agreed that there would be no hard questions when I talk. No, it's a great question. It is the question. In cancers where we don't have data where we can accurately tell a patient that acting on this test is going to change their outcomes, it's really highlights the importance of the shared decision making, where we need to say, look, we're gathering this data for the purpose of building a research database to understand, but we don't yet act on this. And so we don't act on it in clinic at all right now because I just don't think there's data. I think it's very likely that if, let's say, you took someone who got chemoradiation and surgery and they had residual disease and you were thinking about giving them nivolumab as per 577, I think in a negative patient there, I expect we'll have data where you'd say that Nivo may offer no benefit to them, but may offer toxicity of immunotherapy, whereas someone who has a positive test, one, we're obligated to understand those patients and see if nivolumab actually clears the ctDNA in those patients, or if it doesn't, if it's not an adequate adjuvant therapy, that's equally important to know, because then those are patients where we say we either need to intensify the adjuvant or you really need the nivolumab because there's a subset who are cleared. But in our own clinic, it's very clear that this is a research tool. Our job is to build the databases that led to some of the colon data, and ultimately we're not acting on the result currently.
Sam, great talk. What do you think about this? You brought up the idea of doing both tumor-informed and non-informed assays. I mean, I think this is a great topic to think about, because especially in the neoadjuvant setting where you might have different clones in these tumors that you might miss by picking one piece of the tumor versus, because for example, in rectal cancer or anal cancer, or maybe even a big, GE tumor, you could pick a bunch of different spots, and even if you use a tumor-informed assay, you might miss a clone that's going to be the one that comes back and kills the patient. So I think bringing up this trial, which we've thought about a little bit, but maybe you can expand on that a little bit. I mean, maybe it's super expensive to think about, but when we think about patient outcomes, anyway, I thought of just something maybe you could expand on a little bit.
Yeah.
I find that very, very interesting and provocative.
Yeah, I think this paper did it, and actually the Asian gastric cancer series that I showed you did the same thing. So essentially you're taking a test kind of like Guardant, let's use as an example, where there's a panel of predetermined genes, let's say it's 200 or 80 or 400, and I suspect that as we increase the panel size and the performance of the tests, that we may get to whole exome level or whole genome level where we can overcome some of those limitations. But let's say you're basically doing a Guardant test plus a tumor-informed test. And the idea there is exactly as you said, that there are some clones where your predictors of which truncal variants to track don't capture all of the population. So if there's an emergent lung metastasis that was there and it has a different genomic profile, your tumor-informed test is basically blind to that. I think we don't know how common that scenario is, and that's a really important piece, because here it was a very small subset of patients where the tumor-informed would have missed them, and that will be really on us to figure out if it's 10% or 15% or 40%. But there, again, using Guardant as an example, the Guardant picked up something, and that's a patient where, exactly like you said, it's real. It looks like those patients performed the same as if their tumor-informed test was positive, so the prognostic impact is real. I actually think personally that's the way the field will converge upon. The technology advances so fast for these tests that I think we'll probably wind up incorporating informed, uninformed, methylation, maybe even other markers like protein, where the sensitivity gets better and better. I think these multimodal tests will probably have a place. I don't know exactly what it will be, but yeah, it's a very important point to think about when designing trials and what assay you want to pick for your benchmarking.
One comment on the uninformed one, that the panel. Sorry, one comment on the uninformed one. I'm Tony Malioka from Protean. The uninformed are often selected on actionability, so that if those are there, that it does give you a therapeutic option, whereas the tumor-informed ones may or may not have that. So that's one advantage there. Do you have any comments on circulating tumor cells? Because I think they may be coming back in terms of particularly with antibody conjugate therapy.
Yeah, so we've obviously been talking about pieces of the guts of tumor cells, the DNA and et cetera. But there are, of course, in metastatic cancer patients and non-metastatic patients, some cells break off from the primary as a whole cell. And so there's circulating tumor cells, and there's a lot of different ways to capture them from the blood. And there are some potential advantages. With the whole cell, you can get information about surface protein markers that are impossible to get from circulating DNA. And so it's not exactly my area of expertise, but I think it's always been kind of a sensitivity issue, is my understanding. But if you can enrich and isolate, then I think they would have similar performance as ctDNA. I think it's probably doesn't seem to be the leading strategy right now. But your other point about, we're all used to, in stage 4 patients, using ctDNA to genotype patients for like a BRAF mutation or a KRAS mutation. Tumor-informed approaches, that's not the goal. You're not trying to genotype the tumor for targets. That's more, as you said, an uninformed use in the advanced setting. It remains unclear if that actually matters in the non-metastatic setting. That's exactly what the ACT3 trial is asking a little bit, where let's say you finish your FOLFOX adjuvant therapy, you have a positive test, and the positive test identifies that your tumor was BRAF mutant. You actually, instead of getting FOLFIRI as your early metastatic therapy, you would get a BRAF-directed regimen. And so whether early biologic targeting also accomplishes the same goal is a fair question, but I don't know the answer.
I do have a few virtual questions. First one is, how do you order ctDNA?
How do you order it?
Yes.
Yeah, that's a good question. So it's, I would say institutions and health systems are probably implementing this in a different way. So we just went with like an electronic order where now we can order it through our medical record. And then on the back end, what happens is somebody is filling out a requisition form and sending it in. And you know, I have the luxury of working in a place where there is some people who are doing that for me, but in clinical practice, it's like ordering other molecular tests in an advanced setting. You have to complete the form, and patients have to consent to the use of the test. And you know, obviously there's the whole insurance angle, which again, thankfully I try to know as little as possible about. But it is important because financial toxicity is real. But it's for blood tests, it's basically like ordering any molecular blood test is a requisition form, usually a send-out test. Most of the tumor-informed approaches are ordered the same way, and on the back end, the companies that do this will call to get the pathology sent to the, you know, their lab to build the assay. I hope that answers it.
Thank you. And then the next one is, could you please elaborate more on your slide titled Series ctDNA Testing, Post-op ctDNA Negative? How do you determine or use VAF and adjuvant FOLFOX?
Yeah, so I think that maybe I just didn't pick the best picture for the slide, and I actually stole it from Dr. T, but I think this is the slide you're talking about. So this was a presentation at ASCO GI just a couple weeks ago, where she's one of the experts who led the dynamic trial, the New England Journal paper, and this is an example that she used because the test that they used in the tracked predetermined gene panel. And so here, again, the point is the rising variant allele frequency here is a surrogate for tumor burden. So let's say here your test is positive at a very low frequency. So let's pretend that this is a 1 millimeter lesion in the lung that you can't see. As this is going up, it's generally telling you that there is more tumor cells. And so the allele frequency is rising. It's a surrogate for tumor burden. And so let's say here it went from 1 to 3 to 5 millimeters. We don't use the variant allele frequency clinically in routine practice, especially some of the tests don't even report out the variant allele frequency. I think the take home here is really the negative to positive conversion is the most important thing. So I can't say that myself and maybe others are different. We look at sort of the semi-quantitative values just to see if it makes sense. And so if you see a rising MTM or variant allele frequency, it usually tells you that there is an increase in the amount of disease somewhere. You know, your scans are not showing anything. And so here, again, this is the exact scenario where we don't have data to say that if you pulled the trigger for chemo here, or if you pulled the trigger for chemo here, or if you pulled the trigger for chemo here when the PET scan showed something, that there's a difference. We don't have that data yet, but that's exactly the data that we want to get.
And then last one, what do you do with a patient who got positive test, adjuvant chemo, and remains positive?
Yeah, so great question. Don't know the answer, but it's exactly, well, I think this one might even show it better. Okay, so these are those curves that speak to that. And one, we can tell that patient that we're very worried about them, that they're very likely to progress to metastatic recurrence. And so here is people who were positive and stayed positive. Basically, the vast majority of people recurred. Same thing here. People who did not clear after adjuvant therapy, very reduced disease-free survival, so very high rates of recurrent disease. We don't know what to do. That is the next scenario, and colon cancer is just an example because it's one of the more common tumor types, and they generate data very fast. I'm sure that these curves would be very similar if I had the data for gastric or pancreas or cholangio, et cetera. But I don't know if anyone else knows the answer, but I don't know exactly what to do. Someone who's positive after adjuvant therapy, other than be worried. Enroll them in a trial is the answer, but again, I think it drives home the need to all participate in these trials.
What's the tool negative protected rate. There's a false there's a false negative protect. How much the rate? Those tests.
So then, like your negative predictive value.
Negative predicted. If it's a false, because there are some negative, is protected negative actually is true positive. What's that rate?
Yes, I think it, obviously varies a little bit from test to test, and I don't know all the numbers. I'm trying to think if I have any slides that speak to that directly. I don't think so, but the negative predictive value is very high. The positive predictive value is much higher because a positive is true, like most of the positives are true positives, and those people will ultimately recur. The negative predictive value is not quite as good, but it has been good in the series that I've seen that report it. It's relatively uncommon to see a negative convert to positive, as in, or I'd say a positive convert to negative without any therapy, so that would be like a false positive. I think I've maybe seen that once or twice, and it may be related to the timing, and I think some of the data I showed earlier might speak to it a little bit, but I don't know the negative predictive value off the top of my head, but there are certainly patients where the negative predictive value is definitely improved by serial testing. So the sensitivity of one time draw right after surgery may be somewhere in the 50% range, which is not perfect by any stretch. And so that's why in the dynamic trial and some of these other, they had like a short interval repeat, because if you have two negatives in a row, then you feel much better. And so I think maybe the take-home point is that if you have a negative and you're worried, it might make sense to check it again.
Yeah, that's true. If a clinic is a high risk, test is negative, you have to do another test.
Yep. Improve your confidence. Totally agree. Obviously, this is a huge topic with a lot of interest. I don't want to take time from anybody else, but.
No, I was thinking exactly what I was thinking. In case of, there are cases of where you get a positive and then it turns negative. And are there any factors that can make you have a false positive test?
I think there probably are. I mean, certainly depends a little bit on the test and the platform. As the technology improves, I think that will be increasingly less common. But I think timing is probably the one that people have looked at the most. And very, very early time points, like day after surgery, is probably a bad time or a less well time to do it. I would encourage you to look and dig into the supplemental data from the dynamic trial, because they do report, and I'm sorry, I just can't remember the numbers off the top of my head. They do report the portion of patients who had like a positive at 4 weeks and a negative at 7 weeks, or the vice versa, a negative at 4 weeks and a positive at 7 weeks, and they do describe the outcomes for those subsets. I don't remember off the top of my head, but I think the theme was that if you were negative and converted to positive in that short 3-week window where nothing happened, you basically performed very similar to if you were positive all along. And the people who were positive at 4 weeks and negative at 7 weeks with no intervention did well, maybe a little bit closer to the negative. So it does happen periodically, and I think it's probably a feature of the timing of the test and the test design itself. But I know that's not a perfect answer.
Thanks.
Thank you. I will now invite Dr. Thatcher Human from Vanderbilt up to the stage, and he will present on pancreas and hepatobiliary tract cancers.